Good afternoon, everyone, and happy International Women's Month. It is really wonderful to have you all here with us today. I want to start with sobering reality that every 2 minutes a woman dies from preventative complications related to pregnancy and childbirth, and nearly 95% of this death occur in low and lower middle income countries. Globally, 1 in 5 childbirths are done by a C-section, making C-sections the most common surgeries that are life-saving as well. Thus, making C-sections not only accessible when for the right indications, but also safe is critically important. Safe surgical obstetric care is more than just expertise and technical skills. It's also about effective communication between interdisciplinary healthcare teams, nurses, midwives, physicians, and others, and respectful and effective communication between patients, their families, and their healthcare teams. Why should we care about this? Because approximately 80% of serious medical errors are actually attributed to poor communication. So, as we think about training the next generation of healthcare professionals, the question becomes how do we go beyond teaching technical skills to building excellence in teamwork, leadership, communication, and patient centered care so that every pregnant woman can transition to motherhood safely without risking her life and the life of her baby, and she can do so no matter where she lives. Our team at the Center for Global Health and Social Responsibility at the University of Minnesota has been collaborating with the guests on our panel today, as well as many others, to develop simulation-based training for safe C-sections with a particular focus on team and patient communication. I want to take this opportunity to give a shout out to all our partners, our simulation partners at the MSIM, University of Minnesota, our SIM team at Kaiser Permanente Northwest, we've been big partners, global partners at UGHE in Rwanda and Mekelle University. And today, we are excited to learn from our panelists about their experience with this work, but also their broader perspective on what transformative obstetric, surgical, and maternal health training can look like. So it's a real pleasure to introduce our 3 panelists to you today. Dr. Zega Gabra-Mariam, she's an OBGYN and assistant professor at Ida Comprehensive Specialized Hospital at Mekelle University in Tigray, Ethiopia. She brings frontline clinical experience and research on maternal outcomes. Thank you, Dr. Zeka. Dr. Halle Taka, who's also an OBGYN and associate professor at Mekelle University, College of Health Sciences, widely recognized for his work in research, mentorship, and advancing obstetric care. Thank you for being with us. And Dr. Reed Gamble is a fourth-year OBGYN resident at the University of Minnesota with a background in bioethics, who did his resident research on informed consent for C-section in Ethiopia and Rwanda. Dr. Halle was actually one of his mentors. So it's really wonderful to have all of you here today. So before we start, a few housekeeping items. At the end of the panel discussion, we will take your questions. Please drop your questions at any time during this discussion by clicking on the Q&A button at the bottom of your screen, and our panelists will do their best to address them at the end of the presentation. We will also share a link to a short survey to get your feedback about the program. We hope you'll fill it out. So with that, I'm going to start the panel discussion. I like to pose this first question to all of the panelists. So, I think we can all agree that we need transformative strategies in obstetric surgical training, particularly when it comes to communication skills. So, my question is, what does transformative surgical training mean to each of you in practice, and why is strengthening communication skills, for example, in the context of informed consent for surgery, such an overlooked part of our training? Dr. Zagga, perhaps you can share your take on this first.
Okay, thank you, Dr. Rahel. So regarding with transformative surgical training, we have to first think about what we were doing previously as in the traditional way of training the trainees, which is basically it was focused on how to train them on a technical aspect of it, and it was never focused on the soft skills that were needed to have that smooth communication with patient physician communication. And we've never had that focus on the communication skills to attain this focused way. And another thing is on how to use the simulation in attaining this, how to transfer the soft skills to the trainees, where the most important things that we need to mention. And then I will let the other panelists continue.
Thank you, Dr. Zaga. Dr. Reed Gamble, what are your thoughts?
Yeah, I echo those same sentiments about the soft skills required to be safe practitioners, especially surgical practitioners. As a trainee myself, I think it's important to take a step back from some of the surgical technique and to understand the importance of communication, specifically related to my interest in informed consent. And it's something that I think we are realizing now globally is accounting for a lot of maternal morbidity and mortality rather than just the surgical skills. So it's the entire picture. And it's something that as we continue to have that conversation and train young people in the field how to do it, it will become more day-to-day practice and will improve maternal outcomes and fetal outcomes as well.
Wonderful. Dr. Halle. By the way, I'm going to call Dr. Halle and Dr. Zaga by their first name because that's how we do it in Ethiopia. So in case the audience is wondering. So Dr. Halle, go ahead.
Okay, thank you very much. Hello, everyone. Thanks so much, Dr. Rahel and your team for having me and for giving me this opportunity. So I would say we have to start to change how we define a good surgeon. So a good surgeon usually is defined in our context as someone who operates well and who, for instance, we ask our trainees how well they have operated, how fast they have done their surgeries, and if they have controlled bleeding or how many procedures they have done. I know that are important components of clinical skill. However, to say a surgeon is complete, he should have also have a good communication skill and transformative surgical training for me means to care for the whole patient, not just the procedure. If we forgot how to communicate with patients clearly and how to, have an informed decision-making process, we are just treating the procedure, not the mother in a whole. So a good obstetric surgeon must also communicate clearly, obtain genuine informed consent. We have to show empathy, and usually the reason why I believe we focus on the technical skills is because they are easy to measure and they are easy to see also. So they are easy to observe, they are easy to test, they are easy to count. But recently, you all would know that for a success, even for at individual level, this emotional quotient, communication skills are very important. So for a surgeon to be successful, the surgeon needs to have also soft skill and emotional intelligence skills. And that way, the operation, the service that we provide, the mothers will be complete. Back to you, Dr. Rahel.
Wow, I love that. I love all of your perspectives. And I like the idea of changing the way we define what a good surgeon is. That's a very important thing, even the language that we use. So thank you for that perspective, Dr. Halle. Um, I'm going to now go to each of you with kind of a slightly different question. Dr. Gumbel, you are a fourth year OBGYN resident at the University of Minnesota. So you have the perspective of somebody who is currently in training, and you're actually going into fellowship. So you'll be in training for a while. So tell us a little bit about your experience with global health engagement as part of your global health track training program at the Department of OBGYN. And how has this experience expanded your understanding of the importance of, ethical and culturally appropriate communication with patients when it comes, for example, to informed consent for C-section?
That's a great question. As you had stated, being, at the end of my OBGYN training, but also at the beginning of a new wonderful opportunity and fellowship, education and also just learning is at the forefront of every day when I'm in the clinic or I'm in the operating room. And I think one of the things that we are missing in surgical training, as stated by my colleagues before me, is this, discussion around what does it mean to make a complete surgeon. And I was really fortunate to be able to have great conversations with early mentors, including yourself, Dr. Nardos, specifically in the field of urologic gynecology, but also in the field of global health about utilizing that global health track or that global health experience to really broaden my understanding of what it means to be a great physician or what it means to be a great surgeon. And it's right in the name of the department, social responsibility. It's, I think, our goal and our what we are hoping to do is to create partnerships to extend our web and our interconnections between surgeons so that we can learn from each other. It is a reciprocal relationship, and coming from as a med student and kind of before medical school, you think of global health as providing resources or perspective of providing an not available surgical procedure. But that entire phenomenon really was kind of flipped on side of its head when you really look at sustainable global health partnerships and collaborations and how we both need to learn from both of our own systems to care for everyone. And I would say as someone who's initially was, I would say, a little bit hesitant to join the field because of kind of the history of global health, I've really learned how we can responsibly interact with our partners and we can create research partnerships and we can learn from each other in a way that will better both patients here, but also patients in Ethiopia and Rwanda, as well as going to answer that question of what it means and what it's required to be a exemplary surgeon and excellence in surgery. And one of those things was communication, and I think that has been shown. Just being able to communicate with our partners in other countries, being able to communicate and to exchange ideas, assists you in that process of how do you talk with a patient, how do you talk with someone who is in your own backyard, who may have barriers, whether it's language, whether it's cultural, and so this opportunity to work in the global health field has definitely started to answer some of those questions of what makes a wonderful surgeon. And I've been really grateful for it.
That's awesome. That's a great, opportunity to kind of shift your mindset too. It seems like. And I'm just going to ask one more kind of question, just based on that experience of, I mean, you collaborated with partners in Rwanda and Ethiopia, Dr. Halle being one of your mentor, and part of your research was to learn about challenges that healthcare professionals have in these countries when they're trying to do informed consent. Can you tell us a little bit about what you learned from this and how it compares to some of your own challenges here at home?
Yeah. The project was surrounding those barriers to informed consent or creating a landscape of providers' perspectives and relationships with that process so that we could create simulations to better assist them. And what I learned specifically or personally was that everyone, the vast majority of surgeons are very well intentioned and are following the guidelines that are provided for them. But when the expectations of reality fall outside of those guidelines is where where things become difficult. And so I've learned how people are very creative about how trying to gather informed consent, but also how people are frustrated that they may not have the skills or that the system has not provided them with the skills necessary, and they acknowledge that barrier and also that gap where they feel like it's that uncomfortable communication skills or that uncomfortable relationship is present because of situational barriers, whether it's violence towards providers, whether it's lack of education and rural settings, whether it's perception of female providers being inferior and unable to have that kind of trust between the patient and providers. Um, the vast majority of people have the intention of protecting the mother and empowering the mother to make the best decision, but they lack sometimes those skills, and that's where our simulations come into play of how do we fill in the gaps where traditional informed consent teachings have missed.
Wonderful. And I know you are working on sharing what you learned, hopefully as a publication soon, and hopefully we'll learn more from your experience, Dr. Reed. Um, I'm going to turn to Dr. Halle and Dr. Zaga. You're both clinician and educators in obstetrics and gynecology, so you've trained a lot of students and residents at Makerere University. My question for each of you is, what does effective mentorship look like when you are doing training, not just technical skills, but also communication skills? And what are some of the challenges that you've faced, especially if you have some examples as well? That would be fantastic. So, Dr. Halle, maybe I'll get started with you.
Okay, thanks again, Dr. Rahel. It's a very important question about mentorship. So when we train residents, are we just training them, then give them scalpels and then send them to operate? So they will literally be, I mean, if the human skills are lacking, so we are just training butchers, as they say. Sorry for my French, but there should be a complete set of the human skills, like I said initially, and as well as the technical skills. I'm not saying technical skills are not important, but both are equally important. So for me, effective mentorship means teaching three things at the same time. One is teaching the hands, second is teaching the head, and third is the voice. So the hand, by hand, I mean the technical skills, and the head is just judgment and decision making, and the voice is communication. So I say all are very important. So if we only teach technique, we may produce someone who can just operate, but not necessarily someone who can make good decisions or guide patients safely and respectfully through care. So we ask our residents how they are operating, how urgent or catastrophic things were, and so on. But we sometimes forget the patient as a whole, communicating the patient as a whole. So residents basically learn from us doing it also, not just from providing lectures or telling them what to do, but sometimes they may really observe how we communicate patients in difficult situations. Obstetric procedures, particularly cesarean delivery, usually happens in an emergency setting. So if we don't do it ourselves, if we just tell them what to do, they may not really able to pick. So we need to involve ourselves. The residents should see us, communicating with a patient under pressure. That way, it will last. So residents will learn better by observing us doing it. I hope Dr. Saga will have more to say. Thanks, Rahel. Back to you.
Thank you so much. And you bring up a really good point of we ourselves need to be role models. And honestly, if we ourselves were not trained the right way and we have our own kind of way of doing things, that's what the learner is going to learn. No matter how much you tell them, if you don't show them, they just follow what they're seeing. So that's a really, really important point. Dr. Zaga, please weigh in on this discussion.
Okay, thank you again, Dr. Rahel. And on top of what Dr. Halle has said, we always have the habit of having one way of teaching. There's also a way of getting the feedback, even with the communication skills. He has mentioned that we have to train the hands, the brain, and the voice, but also we have to know on how to do the feedbacks as well, for the lack of redundant communications as well. I'm not going to repeat what he has said, but the feedback was as if for the simulation trainings, for example, there was always a sessions where everyone gathers around and said what could have been better, for the communications, what could be added, what could be decreased, and especially in our low resource setups where literacy may be a luxury in some setups. You need to have you need to communicate a better way of on how to get across your information without having to scare the patients, and that includes on feedback, feedback from the residents, feedback from the interns. So the effective mentorship is not just one way around. It's also having to have an open mind and receive what could have been done better.
Fantastic. And, in addition to the role model idea, what you're bringing up is also the value of practicing these things in a simulated scenario. We'll be talking about that because that's one of those strength of a simulated communication practice is that it's a safe environment where you can practice not only the communication but also how you give feedback and how people receive it and how they incorporate it into their practice. So I'm really looking forward to digging deeper into that. I want to come back to you, Dr. Halle. So, shifting from training to what it actually looks like in real world in your practice, you've been, obviously collaborating with our team in co-creating a simulation-based training modules for informed consent during non-urgent and urgent and emergency C-sections. My question is, what are some of the challenges that healthcare providers face in your setting when trying to conduct an ethical and culturally appropriate informed consent? And B, how would the simulation-based modules that you have co-created help overcome some of these barriers?
Okay, thank you so much, Dr. Rahel, again. Like I said, unfortunately, in our setting, the soft skills have never been treated seriously as technical skills for several reasons. So while developing the modules with you and reviewing also literatures, what I found out is that uh, what are the reasons, what are the challenges not to provide an adequate and informed consent. So one is time pressure. Time pressure. What do I mean by time pressure? So in our setting, you don't know how many patients you are going to see, for instance, in a day, and you don't know how many cesarean deliveries you are going to do. So you are always in a hurry, and you would always end up saying, "Let's do the cesarean delivery." So time pressure is a very one of the most important challenges because the physician to patient ratio is very low, and there are less skilled healthcare professionals. But I believe we need to, regardless of the situation, we need to give an opportunity for the mother, for her voice to be heard and to feel that she is part of the decision-making process. So the other is problems with the patient herself. Maybe the patient is in pain, frightened, exhausted, and sometimes overwhelmed, and patients are referred from hundreds of kilometers. And the other thing with the patient is she might be hearing the technical words, like Dr. Sanga was saying, for the first time, like obstructed labor, fetal tachycardia, fetal bradycardia, whatever. She might be listening to these things for the first time. So this is really confusing. This is one of the main challenges. But as I always say and believe, if you tell people with a language they understand and with the level of education they have, like so, if we explain the terms clearly, everyone can understand. So everyone can learn and understand if we clearly explain things. So the other is with the decision-making process. In our setting, mothers are not the ones who are actually making the decisions. For instance, if a mother consents for cesarean delivery, so without the knowledge of the partner, she might end up, in divorce. So the husband should be involved, family should be involved, and usually mothers delegate their decision-making responsibility to their husbands and to their family and so on. So this is one of the major challenges. So we, as much as possible, we need to involve the parents because we have to understand the environment that the mother is going, is going to, she's going to live later. So we don't just say the mother is the ultimate decision maker and we don't have to, ignore the decision in the decision making process, the parents, the partner, elderly, and so on. And sometimes in our setting, for instance, a mother would say, "Today is Saint Mary's Day, so I don't want to have cesarean delivery to be done." And there are so much religious people, and they advocate for their religious practice and so on. So what I would say, we really have to explain if it's urgent or emergency cesarean delivery. But if we can accommodate it for elective cesarean delivery and so on, we don't have to say I don't care about religion or if you want, let's do it today and so on. So we really have to adapt and accommodate patients' wishes, culture, and religious practice. So the other thing is hierarchy. Patients tend to say, you know better. We all know. The audience can understand that in our setting we follow a truly paternalistic approach for decision making. The physician acts as a decision maker. The physician acts as a father and makes decisions for the good of the patient. I am not saying this is a good practice. We really have to involve the patient, and the patient should really understand what we are doing. So, as much as possible, the patients should be involved, the parents should be involved, and if there are elderly, so they should be involved, so that when the patient have her treatment complete and return to the community, she feels that she has fulfilled the religious duties and the cultural practices and so on. So this is what I can say, Dr. Rahel. Thank you very much. Back to you,
Well,
Dr. Rahel.
there's a lot packed in there, Dr. Halle. Really, I think that was at the heart of some of the work that, we were doing on the modules is how do you make shared decision making, taking the woman's voice, but also acknowledging everyone else? How do you take culture and society into consideration and still do a good job? So these are all great points that you bring up. Dr. Zaga, as part of our collaborative work, you and your colleagues in OBGYN nursing and midwifery received training specifically in as communication simulation facilitators. Tell us a little bit about that experience, but also what that might bring to augment the traditional approach. You already highlighted some of the limitations of the traditional approach. So how does some of this work that you've done kind of help you be better at training the next generation?
Okay, and I'll start with the previous practice of having to take the informed consent. So usually what it was done was a nurse or a midwife is going to counsel the patients on cesarean sections. And the physician, because there is a supply and demand mismatch, which means like the physician gets to see a lot of patients and not enough time for having to take the informed consent. So usually the midwives are the ones who take the informed consent, and the physician or like the resident or the OBGYN stays in the OR for the surgery. And this compartmentalizes the team as a whole. So what I've seen in the training, which was informative and also like a next step in patient care, is it involves the whole teams at the same place. So like even in the examples in the videos that are shown, shows that the introductory part is there, and there is also introductory part for the team and what their work in the whole patient treatment is. So this increases patient trust as a whole, which is like another step in patient care, as I said. And another thing is it also like classifies the simulation trainings, classifies it as emergent, urgent, and elective cases. So for each of them, they have like allocated time, and we have never had this kind of experiences or practices. Unless you practice, you kind of panic at a time where there needs to be like immediate information. So if you practice it, it makes it more easier. Like, okay, how can I give this patient enough information in 5 minutes? Okay, what can I do in 10 to 15 minutes? When it's practiced that way, and the whole team also is involved, and when the practice is put into like the proper patient care, then the whole shared decision making and informed consent process goes as smoothly as possible. So this was what I've seen. I think let me give the chance to the other panelists.
Yeah, this is fantastic. And I think practice makes perfect. That's kind of what you were saying. And also the safe environment to practice it makes a big difference, especially for interdisciplinary teams where there might be a lot of hierarchy between doctors and nurses and midwives in the real world. Like how you flatten that hierarchy through practice is also fascinating. I'm going to come to a different part of this panel discussion where we can dig in a little bit more on this topic of the fact that medicine is a team sport. And you gave a good example of how midwives tend to do the informed consent, even though they don't operate. And we learned from the midwives that this is not a really good way to do it because they are not the surgeons, right? So when it comes to the full spectrum of surgical care, the surgeon only plays a fraction of the care spectrum, whether it's pre-surgical, during the surgery, or post-surgery. I think you guys have all emphasized the importance of interdisciplinary communication. I guess my question for Dr. Hale and Dr. Zagga is, how do you teach people how to do this in the real world? Like, let's say, you practiced it in a simulation environment even. It's one thing to practice in a simulation environment and another thing to actually really practice it in the real world. So do you have any insights into how you can better train real teams on this? Dr. Hale, you want to take a stab at it?
Okay, thank you very much, Dr. Rahel. So, what I believe is that interdisciplinary communication matters because surgical care is never offered by a single individual, be it the surgeon, the anesthetist, whatever. Even the cleaner contributes to the expedite surgical process. So at the end of the day, the experience is just one system, one team, and one story. Regardless of what contributed, at the end, it's one system, one team, or one story, or one patient. So if the midwife says one thing and the surgeon says another thing, For the mother, it's just a system. If she come to our hospital, for instance, she would think about the hospital, not about the nurse, not about the physician. So she will definitely be confused. So the resident and the midwife, the surgeon, the anesthetist should, as much as possible, speak the same thing, so the mother would feel safe. If the midwife tells her something and the surgeon tells her something, for instance, mothers who came from remote rural settings, they wouldn't understand even who the surgeon is, who the anesthetist is, and who the midwife is. That's where the importance of team communication really matters. So the training that you provided with your team in either. So it simulated this the whole scenario. Like there were obstetrician and gynecologists, there were midwives, there were resident physicians, and yeah. So the whole team was trained, and that was an eye-opening experience for us, honestly. So it's very, very important that as much as possible for a specific case scenarios, for instance, for cesarean delivery, we should have some handouts that we all speak the same language so the patient feels safe at the end of the day. Thank you.
Really incredibly simple and intuitive, but yet often overlooked truth that you just tell. Dr. Saka, you have anything to add to that?
Yeah, I think on top of what Dr. Halle has said, it stimulates at least on what to do on the right way, but it needs, I think, continuous work to be on the realistic side of it, to practice the emergency in the urgent, the emergent and the urgent cases. It needs a repeated practice. It's not just like one training and you can just like deploy them and do it. It needs facilitation at a time where there is an urgent and emergent conditions. And on elective cases, it would be easier to follow through and to facilitate the condition. But and on the emergency cases, we might have some difficulties on following through. I have to add that.
Yeah. So I think you brought a very good point, which is even when you produce like training materials like the way we have done, just doing it once doesn't, mean that it's gonna stick, right? So you have to incorporate something like that as part of the regular training program on a regular basis, and then there has to be some sort of oversight to see how well some of this learning is being incorporated in the real world. So that's the challenging part, and hence the reason why I think we need good champions like you guys kind of caring about
Maybe
this.
one point,
Yeah,
Professor.
go ahead.
So one point that are not very common in our scenarios that we got from the training is like hurdles. We don't do that too often here, and we don't also debrief at the end of surgeries what went well and what went wrong and so on. So I think these small steps are important to align, and at the end. Better communication is not just about one person speaking well. They say it's about the whole team creating a consistent, respectful, and patient-centered experience of care. For that to come, we need to have play a very small role play before we do the surgery, and then debrief also. We need to have hurdles and then debrief, and that was an eye-opening experience for me from the training. Thank you.
Great insight. And Dr. Gamble, do you see a benefit to this kind of approach of, as simulation for team communication as a great way to teach, even in the US setting? Can you tell us a little bit about that? I mean, does your training currently include that? And if not, do you see an opportunity?
Interestingly, that's a great question. Interestingly, they do not. The first time I learned to do informed consent was in the labor room when a patient, had terminal bradycardia, and my senior resident was whispering to me in my ear what to say to the patient who was like visibly crying, and we were telling her that her baby was dying and we needed to emergently get her baby out. So I think it's almost like you have a trauma response as a provider, and I think all providers, OBGYN specifically, can remember that first time when they ran into a room and tried to explain to a patient and their breath was really shaky and their heart was racing, trying their best to explain it, but also learning on the spot. And so I think rewriting that narrative, which all of these wonderful experts here in simulation are trying to do, is create a safe place for residents to experience that emotion and that physical manifestation of symptoms when you're talking about life and death decisions and talking about surgery and using an interpreter or having language barriers. These are all real barriers that are difficult to jump into on the spot. And so having simulation is an incredible opportunity to be in a safe space to struggle because this is not an easy task. And I think that it is an utmost importance for like all OB/GYN residencies around the world to have these simulations, regardless of they're in a low resource, high resource setting, to have that experience, because we all are going to have that same moment when we are jumping in and we don't know what we're doing. And so to be able to experience that, not when the patient, with a real patient, is very monumental.
Mm. That's great. I mean, it kind of makes me think the whole value of global health partnerships is to develop things that we can all benefit from, not just to help other people, as sometimes the traditional way of doing that has been, is that the work that we do, we need it just as much as anyone else, So this is a good example of that. This is a good transition to, we're almost coming to the end of our time for the panel discussion. I like to leave a little bit of time for a quick Q&A. But if each of you, I'm going to just shoot one question to each of you. If you can answer it in very briefly, like in a minute or so. Dr. Halle, from your experience in global partnership, um, eh, I'm kind of curious to see, what your idea of a sustainable collaboration partnership, definitely beyond one single project, would look like. Like, what's your view of good partnership?
Okay, thank you very much. It's a difficult question to answer in 1 minute. I'll try my best. So I served as head of international relations in 2015. That's when I knew Rahel. So it has been more than 10 years. Apologies for not referring you as professor and so on. We just get used to calling Hale and Rahel already. So for me, a strong global health partnership starts with respect. That's the most important thing. So partnership or collaboration or global partnership in general is not charity, it's not control, and it's not one side deciding and the other side receiving. It has to start with trust and mutual respect. So, like I said, I was managing 45 international partners at that moment. I was as the head of IDER, and we had that was at the height of global partnership for IDER. We had 45 international partners at the moment. And it's not because we are talking to you, Dr. Rahel. One of the most important partners we remember was Dr. Rahel. You see, Dr. Rahel, when you see her, she doesn't look intimidating. She's so respectful, and she comes with a very organized team. They know their roles, and they know the objective, and they understand what problems we have. So they listen first. What is the problem in the ground? So listening and understanding what's the problem in the ground is very important. So her team, when they come, they understand that this is a low resource setting. So hotels might not be luxurious, they come from the United States. Toilets might not be clean, and the operation theater might not be as comfortable as in the United States. But they always perform. In one trip, I remember they operated close to 40 patients in just a single trip. Such was an example of a wonderful collaboration. So listening, trust, and understanding. Also, when we do collaborations, people should understand that people in low resource setting does not mean they know nothing. They have local knowledge. They understand the complex setting. They have their own local wisdom and so on. So a sustainable collaboration is something that aligns the knowledge, the resource that's coming from the overseas, and then married together. So alignment is very, very important. The other thing is building capacity. It has to build capacity. So it will be a handout if somebody comes, do something or leaves, and that won't be sustainable. Since she asked about sustainability, Dr. Rahel. So what Dr. Rahel with her partners did is she established a urogynecology fellowship program. So I mean, her team should not always come to us, you know. She has trained an excellent urogynecologist, not just one, but urogynecologist that has been trained in our setting. That's the only subspecialty training available in our setting, by the way. So, like I said, during my time, I was leading 45 international partners. None of these, I am not saying they were not important. They were important in their our context, in their own spheres, but the only subspecialty training started and is up and running, and I'm happy to share that I am the upcoming flow for this 2026 is that what Dr. Rahel and her team created. So it has to build capacity, and it has to be managed by a shared ownership also. So I mean, the partner should be shared, I mean, managed by shared ownership. That's what's happening. So the university has hosted the program. Dr. Rahel and her team are doing their level best to keep it running, even in a very difficult situation. That's during the war, the fellowship training was continuing. And like I said, consistency is also very important. I cannot tell you how consistent Professor Rahel has been because it has been more than 10 years since even I know her, and she have continued to partner and collaborate. And I'm so happy that I have an example to explain what an ideal and a wonderful collaboration should look like. So thank you very much, Rahel. So on our side, the problem on the local side, I mean, things that we should also be respectful to people coming, crossing thousands of miles to support our setting. We have to be so respectful. We should not approach them because they are doing something to us personally. If the system changes, for instance, in 10 years' time, I mean, I was collaborating not just to get something from Professor Rahel and her team, but as part of the system. I was just collaborating, and now I am the beneficiary. I'm joining the fellowship program. So the system will have its own way of benefiting those who keep on collaborating, respecting, and so on. The other is communication. Communication is very important. So I usually hear, for instance, partners, they will send an email and then they will send a text through social medias, and then they will ask somebody else to talk to that somebody to respond. They should not go this long, you know. We should make an effective communication to keep, collaborations going. I have taken so many minutes, and I believe because this is very important. Thank you very much, Dr. Rael, and back to you.
Thank you so much, Dr. Halle, and for your kind words. I did not set you up to talk about me, but you ended up using us as an example, which is an honor. We continue to learn and grow in this area for sure. Um, Dr. Zaka, I just want to give you a little opportunity, before we start the Q&A. I hope our viewers can stick around for a few more minutes for Q&A for sure. But Dr. Zaka, you are a woman in surgery. There aren't that many women in OBGYN, even in Ethiopia or in most African countries, to be honest. And I'm sure you've faced different kinds of challenges. Um, do you have any thoughts around, what could be better to create more opportunities and support women entering in surgical fields? And I think that I might end this panel discussion with your reflections.
Okay, thank you, Dr. Rahel. So, as a woman in a male-dominated field, it's not a male-dominated in the Westerns, but in our setup, it's a male-dominated area. So, having to prove myself repeatedly, it's an easy way to burn out. So that's the challenge we repeatedly encounter. And also there are in surgical fields, there are hierarchical barriers, as in usually you're not you're not at liberty to question your seniors, and also there are limited opportunities and limited mentorships. And what should be done in a bigger picture is usually the culture of having to normalize women in leadership roles, women in surgical roles. As a culture, it would be better to know to work on normalizing it, and also like the visibility issue for mentorship, as in like if we have seen, like for example, me seeing you doing what you have done, which is enormous, is it's an inspiration. And also like if I learn something from you, and like if I do a lot, and then I'm sure my juniors will do that too, so it will increase the women in our areas also. And another thing is in supporting in on caring training on at a time where there is difficulty in involving in surgical areas. What I meant is at a time where they are feeding caregivers, women at reproductive age have additional barriers. So at pregnancy time, how to accommodate the training systems at a time where postpartum, these are like difficult times in a woman's time. So the training might be difficult to go at it in a traditional pace. So to accommodate this and have a different way of training could also increase women in surgical fields, I think. Yeah.
Thank you so much, Dr. Zaga. Your voice is really important. I mean, even doing something like this, the panel discussion, and people who watch you, that goes a long way to encourage more people to do the kind of work that you're doing. So visibility, mentorship, all those things, role models are really critical, as you said. So thank you for those insights. And thank you to all of you for this incredible conversation. I like to open it up to Q&A. I know we have a few questions already in the Q&A channel, and I will be posing those to you shortly. In the meantime, we will be posting a QR code for doing survey of this. You know, we would like to get your feedback through the survey. So if you can click on that and fill out the survey, we would really appreciate your feedback. We will also be sending that in our email follow-up along with the recording of this conversation. There were a couple of questions here. For example, this is excellent, insightful panel discussion. How can we expand this kind of training to other institutions? There were also some questions on how they can access some of these resources. So we are actually going to post a link to the UN Surge Hub, which is a big platform that is where our informed consent modules have just gone live, actually, as of yesterday. You can log in, register for free, and actually do those modules with your teams. We did this intentionally to make it more equitable, and we're very grateful to the UN Surgery Hub. By the way, they have a lot of other modules on that hub for surgical training. So feel free to do the courses that way, and you can actually get certification for it, and also share it with others, because we want this to be globally available. The UN Surge site has over 200 country users of different teams, so it has a very wide reach. So thank you, Jake, for posting the link to that. Now, one of the questions says, communication skills are seen as soft rather than technical. How do you ensure they're valued equally in training and practice? Any one of you can give this a shot, whoever wants to respond to that. Don't be shy.
I think one of the biggest, I would say, the key response to that is changing the narrative around, like what Dr. Halle said, was what makes a wonderful surgeon or what makes an excellence in surgery. And so changing the standards to include soft skills, or even maybe changing the word soft to, maybe it is a technical skill, is communication. And so adding communication to be equal with surgical technique and changing in the, standardization of education. Okay, if you're not meeting the standard from communication, but you are technically, you're still not an appropriate place, and then we need to bring you up to par. And so in the training, as a trainee myself, empowering programs and empowering, different countries' training program regulations to say communication is equally as important as surgical technical skills and is a requirement for graduation.
I love that. Another question says, can you share, what makes you, want to do this kind of work, like focusing on team communication, um, kind of prioritizing that in a surgical field, because that's obviously not as prioritized in most settings. What approach would you recommend for more experienced professionals, not just learners, but also, and I know when we talked, even if we are like, mid-level or even upper, senior level professionals or surgeons, we all need to teach by role modeling. And if we weren't trained that way, we may actually be bad role models ourselves, right? So like, how do we do that? That was a question that came up. I know this was directed to me to respond to, Dr. Biniam. I would just say that, when I started as a surgeon first time after my fellowship training, I was working at an institution that really valued team communication through simulation training. So we were actually required to do a 4-hour training called Surgeon as a Leader, but it was entirely dedicated. They literally simulated the operating room. They brought in nurses and scrub nurses and patient actors and anesthesiologist actors, and they gave us all the scenarios to see how we would respond, And it was all focused on how, as a surgeon, I introduce myself in the room, how I introduce the patient to the team, how I empower everyone in my team to speak up if they see any issues with my surgery, and to really reduce any sign of hierarchy in the operating room. And it was a very eye-opening training, and has nothing to do with technical skills. And I thought that I still apply that in my surgeries when I walk into the OR. I love, I saw the value of that, and I believe that number when it says 80% of medical bad outcomes in medicine are from poor communication. So that's why I think this is important. And it's important not just to learners, but also to even practitioners and seniors if they haven't gone through that kind of training. I think it's all valuable for all of us to participate in this kind of work. Does Dr. Halle or Dr. Zagga, you have anything to add to that?
I think these soft skills are currently called human skills already. So, in one book that I recently read, it says even success hugely depends on the emotional skills, like the communication skills and so on, leadership skills and so on. So, it's high time that we combine both technical skills and these human skills into training, and to have just a complete surgeons or complete physicians.
Mm.
Thank you.
Yeah, fantastic. And even how we call it needs to change for sure. So another question is, how do you measure whether there's actually a cultural shift towards safer and more compassionate procedure? Let's say even after you do this training. Any thoughts on how you can embed this kind of thing in actual practice? And this is more, for Dr. Zagar, Dr. Halle, probably, because you have more experience in this settings.
Yeah, so first, the first thing is just to stimulate the hospital staff on that this way of communicating is what's needed. This is the first step. So what was done was that the hospital staff or the team is like stimulated. So and what needs to be done in the future is a continuous work on how it's done and with the feedback and also with facilitation techniques on how they are being done. Unless there is no unless there is a continuous follow-up whether this is done or not, only the training will not be enough on the cultural shift. Usually, what brings a cultural shift, whether this is informed consent on how to do informed consent or any other thing, is a continuous stimulation. So I say like being continuous, consistent, and persistent in advocating. How important this is will help with a cultural shift. If not, it will be stuck, I think.
Yeah, that's the hard work. Dr. Halle, do you have anything to
Yeah.
add to that?
So, I mean, the audience would agree that we ask our residents in training, for instance, did you close the uterus well? Have you achieved hemostasis and so on? So we need to start asking questions also for the human skills. Did you communicate clearly? Did the patient understand? Did you involve the entire team and so on? We should keep on asking equally. I mean, these questions are equally important. So we need to ask both the technical skills and the human skills as well in every patient. So we just keep on ask them how they close the uterus, single layer, two layer, and I mean these are very important. This is a pillar of the patient care. But at the same time, we have to care for the whole patient also. Did she understand? When she go back home, does she feel that she was treated well? Did she understand what happened? Did she understand also what to come next, for instance, when she give birth in the next, about family planning and so on. So communication is so important, and we need to ask equally for the technical skills and for the human skills as well, and consistently, like Dr. Saga asked. I mean, said. Thank you.
Yeah. Yeah. I mean, I think there are some opportunities for that, right? Like, morning rounds, M&Ms, all those kind of even didactic teaching for residency, for example, incorporating some of these things during that time, so that sometimes it's simulation training and not didactics that's done, putting it as part of like the already existing training programs. So it's a multifaceted approach, I think, to make this culture shift and make it part of the system. So the last question, how can you expand this kind of training to other institutions? I will say one thing that we're doing currently is we're building a set of modules on how to actually do team communication simulation, because we had actually trained the team in Magale, like Dr. Zanga and Dr. Halle are trained. One way to expand is Dr. Halle and Dr. Zanga and others who are trained could be champions and go and teach the same thing to other institutions, let's say within the country or even regionally in Africa. And we are trying to build now an actual modules to help them kind of understand the techniques of how to do it properly, how to set up a simulation scenario, how to do debriefs correctly, how to give feedback, the things that they've already gone through, but like make it more accessible to others who are learning to do that. So I hope that answers your question. That's one way of expanding the training to other institutions. Do any of you have any other ideas to add to that?
I think everyone out there in your own respective fields, just remember that the skills, communication, the humanity of medicine is equally important. So just as Dr. Hale, Dr. Sega, and Dr. Nardos have made this or championed this in the institution, means you can also in your own institution champion and ask the questions like, why don't we have simulations, or why don't we empower our learners or empower our attendings to talk about this? And so really asking those difficult questions and making sure to bring this good work to your own home and to your own place.
Great. I would just end by saying, the typical understanding of simulation often is just for technical skills, but it doesn't have to be. You can actually do communication through simulation. And what's great about that is you don't need fancy equipments or instruments or mannequins. You just need humans. You need humans who can practice, who can role play, and then humans who can provide appropriate feedback, and then just the willingness to be in the same space together. So that's the beauty of it. And we're trying to kind of incorporate that culture into the training programs because it's easy to do. And you don't need too many, there wouldn't be too many technical barriers to it. So I hope that it kind of changed your mind a little bit after this conversation on how you see training. And we look forward to getting your feedback through our survey link. And we also have provided a link to our UN Search Hub website where you can access the first set of modules we did. Any future educational modules we develop will also hopefully be posted on this site so that it's accessible freely by anyone who wants to do it, who wants to incorporate it into their own training programs. And we look forward to seeing that. And with that, I'd like to say thank you again to all our panelists and for the audience for being here. Thank you.